Welcome back to the Deep Dive. Today we are tackling one of the most high-stakes, time-critical situations in all of medicine, antepartum hemorrhage, or APH.
We are, and we're getting right into the definitive clinical guide to see what saves lives when, every single second counts.
This is truly emergency territory.
It is. Our source for this is the RCOG, that's the Royal College of Obstetricians and Gynecologists, and their Green-top Guideline number 63 from back in November 2011.
And this document is really the bedrock for management in the UK, isn't it?
Absolutely. It's all about translating global lessons into these very structured, evidence-based protocols that clinicians can rely on.
So just to be clear for everyone listening, when we say APH, we're talking about any bleeding from or into the genital tract from 24 weeks of pregnancy right up until the moment of delivery.
Right, and this isn't some rare thing. It complicates a pretty substantial number of pregnancies, somewhere around 3 to 5%.
And the consequences are, well, that's what makes this so critical. Our mission today is to unpack this guidance, to get past the technical jargon and give you a really clear roadmap of how clinicians define, assess, and manage this relentless obstetric emergency.
Exactly. It's not just about what they do, but understanding why they do it.
Okay, let's start with the sheer weight of this condition. I mean, when you look at the global statistics, the numbers are frankly staggering.
They are. They paint a really devastating picture. The source material points out that obstetric hemorrhage, so that's APH and postpartum combined, accounts for up to 50% of the 500,000 maternal deaths that happen globally each year.
50%. So that's 250,000 lives.
250,000 women, yes. It's a huge number.
And then you compare that global tragedy to, say, the UK context, where the resources and protocols are so much more developed. The contrast is sharp, but APH is still a threat.
It's still a threat. In the UK, the absolute numbers are, thankfully, much smaller, which is really a testament to standardized care. But the confidential inquiries into maternal deaths reported that hemorrhage was still the sixth highest direct cause of maternal death between 2006 and 2008.
So even in that 3-year window?
In that window, 4 deaths were specifically caused by APH. So it's less common, but it's still absolutely lethal.
What that really highlights for me is this idea of avoidability.
Yes, that's a powerful lesson in the data. When researchers looked at maternal deaths in South Africa, for example, they found that a shocking 68.5% of APH deaths were deemed clearly avoidable.
68%?
Yes. And that's not just a clinical failure, it's a systems failure. It's about not having access to blood banks, delays in getting the team together, or not following the protocols. The RCOG guidelines are designed really to eliminate that avoidability factor.
So this document is less a textbook and more a life-saving blueprint.
That's a good way to put it.
Okay, so if APH is the event, what are the 2 main causes, the 2 sort of heavy hitters that clinicians are always thinking about?
We really focus on 2 major causes. The first is placenta previa. That's where the placenta implants too low in the uterus, and it either partially or completely covers the cervix.
And the second one?
Is placental abruption. And that's the premature separation of a normally implanted placenta from the uterine wall.
But there's a really important nuance here that the guideline points out. These 2, while they're the most dangerous, they aren't actually the most common cause of a bleed.
Exactly. This is a huge point of confusion. The guideline is clear that in, a large chunk of cases, sometimes up to half, you actually never find a definitive cause.
What do you call that?
We just label it unexplained APH. And that category can include a lot of things, like bleeding from the lower genital tract, a cervical atrophy, and things like that. It just highlights how varied the condition can be.
Okay, let's move into a crucial part of triage. How you standardize the severity. Bleeding in pregnancy can be confusing, right? Especially because some of it can be hidden.
It can, and that's why these strict standardized definitions are so important. It's because visible blood loss is just notoriously underestimated by the patient, sometimes by the staff.
And you mentioned hidden or concealed bleeding.
Yes. In a concealed placental abruption, the blood can pool entirely inside the uterus, behind the placenta. So the woman could be hemorrhaging catastrophically, but with very little visible blood on the outside.
Wow. So the guidelines have to shift the focus away from just counting milliliters of blood.
Precisely. The focus shifts to assessing for objective signs of clinical shock.
That's the key takeaway then. The mother's physiological response, her vital signs, that's the true measurement of how bad this is, not the blood on the pad.
Exactly.
So let's break down the 4 defined categories that clinicians use for that immediate triage. What's the mildest?
We start with spotting. This is just what it sounds like. Staining, streaking, or a very small amount of blood you'd notice on a sanitary pad.
Okay, and then the next step up is minor hemorrhage.
Right. Minor hemorrhage is a blood loss of less than 50 milliliters, and this is the important part, that has settled. So the bleeding has to have stopped completely. If it's still ongoing, it's a bigger concern.
Then the concern level really jumps up. What's the definition of a major hemorrhage?
A major hemorrhage is a blood loss between 50 and 1,000 milliliters. But crucially, the woman has no signs of clinical shock. Her blood pressure, her pulse, they're stable. If she's compromised, she's in the next category no matter the volume.
And that's the most critical one, massive hemorrhage. And this is where that little phrase, "and/or," becomes so important.
It's everything. A massive hemorrhage is a blood loss of more than 1,000 milliliters and or the presence of signs of clinical shock.
So you could see, what, 500 milliliters of blood?
You could see 500 milliliters, but if she's hypotensive, her heart rate is racing, she's confused. That is a massive hemorrhage. The clock starts ticking, and you activate the major hemorrhage protocol immediately.
The guideline also links the baby's well-being to the mother's status here, right?
Yes, it's a vital point. Fetal compromise, or even fetal demise, can be an early sign of profound maternal volume loss. If the baby's heart rate on the monitor is suddenly very abnormal, or if an ultrasound confirms the baby's passed away, it should be a massive red flag.
Even if the mother's vitals look okay for now.
Exactly. It tells you her physiology is likely on the very edge and you need to act before she collapses. It's an indirect but very powerful indicator of severity.
Now that we know what we're dealing with, let's talk about avoiding it.
Yeah.
It seems logical that if APH is so dangerous, you'd want to screen for it. But the guideline has this almost sobering finding about predicting placental abruption.
It really does, and it's a core lesson for anyone in maternity care. APH has so many different causes that it cannot reliably be predicted. You just can't rely on screening to forecast most cases.
That feels so counterintuitive. We have risk models for so many other obstetric problems.
We do, but not for this. The evidence shows that something like 70% of placental abruption cases happen in women who are considered to be in low-risk pregnancies.
70%.
Yes. The prediction models that have been tried just weren't efficient. They created too many false positives to be useful in a clinical setting.
So if you're looking for a silver bullet to predict abruption,
You won't find one. And that changes everything. It shifts the focus from prevention to just being ready for a rapid, decisive reaction when it happens.
okay, so even though we can't reliably predict it for everyone, there are specific risk factors that really ramp up the danger, especially for it happening again.
Oh, absolutely.
What's the single biggest predictor for a placental abruption?
By far, it's having had an abruption in a previous pregnancy. The guideline is very clear on the numbers. If a woman has had one prior abruption, her risk of it happening again is about 4.4%.
Which is high.
It is. But if she's had 2 previous abruptions, that risk just skyrockets. We're talking somewhere between 19% and 25%.
Wow. So that history alone changes everything.
Instantly. She becomes high-risk, consultant-led care for any future pregnancy, no questions asked.
Beyond that history, what about other associated factors? We always hear about things like blood pressure.
That's right. Preeclampsia, chronic hypertension. They're both associated because they point to underlying issues with how the blood vessels and placenta are developing. We also see links with fetal growth restriction, advanced maternal age, so over 40, and things like smoking.
And substance misuse is a big one here too, isn't it?
A huge one. Cocaine and amphetamines especially, they cause intense vasoconstriction tightening of the blood vessels, which can create shearing forces in the placenta and trigger an abruption.
The guideline also mentions the importance of asking about trauma.
It does, and it specifically includes domestic violence. It reminds healthcare professionals that if a woman keeps presenting with APH, you have to discreetly ask about domestic violence as part of the risk assessment.
I found the link between things that happen early in pregnancy and the risk of abruption later on really fascinating.
It suggests the problem might start really early. For example, having any bleeding in the first trimester increases your later risk of abruption by an odds ratio of 1.48.
And what about seeing something on an early scan?
That's even more dramatic. If an early ultrasound finds an intrauterine hematoma, so a collection of blood in the uterus, the relative risk of having an abruption later jumps to 5.6. It really points to some kind of early vascular problem or an issue with where the placenta implanted.
The guideline also touches on thrombophilias, those genetic tendencies to clot. What's the verdict there?
The verdict is cautious. Observational studies have suggested a weak link, especially with things like factor V Leiden. But when you look at the big systematic reviews, the high-level evidence just isn't there to support widespread screening.
So the bottom line for clinicians is what?
The bottom line is don't go chasing blood tests that aren't going to change your immediate management.
All right, let's switch gears to the other major cause, placenta previa. The source material says the risk factors here are quite different from abruption.
They are, and it's a really important distinction. Abruption often feels like a problem that develops during the pregnancy. Previa, on the other hand, is almost always related to conditions that existed before the pregnancy even started.
So it's about the uterus itself.
Exactly. It's about where the placenta could find a place to implant, and that's often affected by previous damage or surgery to the uterus.
So what are those key pre-existing risks for previa?
Well, having had a placenta previa before is a big one, obviously. Also, having had multiple pregnancies, being older, over 40 is noted. But the single biggest, most quantifiable risk factor is a history of previous cesarean sections.
And this is where the guideline has some truly eye-opening numbers that show how the risk just explodes.
The data is incredibly clear. One previous C-section gives you an odds ratio of 2.2 for having a previa. 2 previous C-sections push that OR to 4.1. But then, if a woman has had 3 or more previous C-sections, the risk just escalates massively. The odds ratio becomes 22.4.
22 times the risk.
22 times. It shows you just how much that scarring on the lower part of the uterus compromises it, making it a dangerous but common site for the placenta to implant.
And what about other things that can damage the uterine lining?
Anything that leads to a less than perfect endometrium is a risk. So a history of a DNC, infections like endometritis, having the placenta manually removed in a prior birth, or even submucous fibroids. Essentially, the uterus is looking for the healthiest spot, and if the best real estate is already damaged, the placenta might settle in a much more dangerous location.
So given all these risks, especially for abruption, which you said is mostly unpreventable, and previa, which is rooted in history, what does the guideline actually recommend for prevention?
The focus is really on modifiable risk factors. So women have to be advised and supported to stop smoking and to address any drug misuse.
Even though there isn't direct data linking that to less APH?
Right. The guideline notes that while specific data linking cessation programs to APH reduction is lacking, we know these programs reduce low birth weight and preterm birth, which strongly suggests an overall benefit to the health of the placenta.
What about nutrition? I know there's conflicting data on things like folic acid.
The guideline highlights that ambiguity. A Cochrane review found no conclusive proof that folic acid specifically reduces abruption risk, but then it contrasts that with a massive observational study from Norway, which suggested women taking folic acid and multivitamins were significantly less likely to have an abruption.
So the advice is?
The advice is just general good practice. Supplementation is encouraged, but we can't promise a woman it will prevent an abruption.
For women who do have a suspected placenta previa, the focus shifts to just not disturbing it. What are the key rules there?
The rules are very strict, and they're all about avoiding mechanical trauma. First, vaginal and rectal examinations must be avoided, period.
Because you could trigger a massive bleed.
You could trigger a catastrophic bleed by accidentally dislodging the placenta. And for the same reason, women are also advised to avoid penetrative sexual intercourse.
And what about medical interventions like drugs to stop contractions or a cervical stitch?
The guideline is very explicit. Tocolytics and cervical cerclage are not recommended prophylactically for previa. The risks of those interventions just outweigh any unproven benefits in this situation.
Okay, we've defined APH and its risks. Now we're in the crucial operational phase. A woman presents with bleeding. Where does she need to be, and who needs to be waiting for her?
This is non-negotiable. Any woman with APH that's heavier than just spotting, or with any ongoing bleeding, must be transferred immediately to a hospital maternity unit, and not just any unit.
It has to have full, multidisciplinary resources. What does that team look like?
It's a whole team. You need immediate access to obstetricians, midwives, the lab, an emergency theater, the neonatal team, and crucially, an anesthetic team and a fully prepared blood bank.
The blood bank is key.
It's absolutely key. Past inquiries into maternal deaths have consistently shown that delays in getting blood products and a lack of a coordinated team response are often where things go wrong.
So the patient arrives. The order of assessment is critical. If it's a major or massive hemorrhage, what is the absolute first priority?
The absolute #1 priority is the mother first.
Always.
Always. If she is compromised, you start resuscitation, airway, breathing, circulation immediately. Fetal assessment is secondary to maternal stabilization. It's a stark reality. If the
Yeah.
mother dies, the baby dies. You secure her circulation first.
Once she's stable, or if the bleed is minor, the history can give you some big clues.
Hmm.
How do you tell the difference between abruption pain and just labor pain?
The character of the pain is vital. If she describes the pain as continuous and persistent, that is highly suggestive of an abruption. If the pain is intermittent, coming and going, that's more likely to be labor contractions.
And on the physical exam, what does palpating the abdomen tell you?
It gives you immediate feedback. A significant abruption often makes the uterus intensely irritable and tense. It's sometimes described as feeling woody or rigid.
And with Previa?
With Previa, the uterus is usually soft, relaxed, and not tender at all.
Now let's talk about the internal exam. The guideline has an incredibly strict rule about this.
It does, and this is a key teaching point for any trainee. A digital vaginal examination is strictly contraindicated until placenta previa has been definitively excluded by an ultrasound.
You have to assume it's Previa until proven otherwise.
You have to. Putting a finger in there when the placenta is covering the cervix could peel it back and trigger an immediate catastrophic bleed. It's one of the biggest never-dos in obstetrics.
But a speculum exam is different. That's actually useful.
Very useful. A speculum exam lets you visualize the cervix without touching it. And studies show it's very successful over 92% of the time at finding those lower tract causes, like a cervical ectropion, which can cause a lot of worry but are often less dangerous. So speculum is good. Digital exam is a no-go until you have that scan result.
Right. So once the physical assessment is done, we move to investigations. Let's talk about the role of ultrasound in diagnosing abruption.
It's limited.
It's very limited, and it's essential that everyone understands that placental abruption is fundamentally a clinical diagnosis. It's based on the patient's symptoms and the physical exam.
So what are the numbers on ultrasound performance?
The sensitivity of ultrasound for seeing a retroplacental clot is as low as 24%.
So it misses 3/4 of them.
It fails to see the clot in 3 out of 4 cases of actual abruption. However, if the ultrasound does show a clot, it's very likely to be a true abruption. The positive predictive value is high.
So a positive scan confirms it, but a negative scan means nothing.
Exactly. You trust the clinical picture of the patient, not a reassuring image.
Now for the blood work, the blood pipeline, as the guidelines call it, what do you need to draw for a major or massive bleed? Instantly, for a major or massive bleed, you need a full blood count, or FBC, a coagulation screen to check for clotting problems like DIC, urea and electrolytes, and liver function tests to monitor organ function. And most importantly, you have to cross-match 4 units of blood immediately.
And there's a warning in there about the first hemoglobin result, isn't there?
A critical warning. The initial HB can be misleadingly normal because it takes time for the blood to become diluted. You have to use your clinical judgment. A low platelet count is a much bigger, immediate red flag for coagulopathy.
And for just a minor bleed.
For a minor, settled bleed, it's simpler. Just an FBC and a group and save is usually enough.
Okay, and every RHD negative woman gets a Kleihauer test. What's its job here?
Its only job is to measure the amount of fetal blood that has mixed into the mother's circulation. That number tells you the exact dose of anti-D immunoglobulin you need to give her to prevent her from developing antibodies. It is not a diagnostic test for abruption itself.
And finally, assessing the baby. Once the mother is stable, what's the role of the CTG monitor?
The CTG is vital. Abruption especially can cause fetal hypoxia. So an abnormal CTG tracing in this situation is strongly associated with a poor outcome for the baby and is an immediate trigger for needing to expedite delivery.
So once the initial assessment is done, a decision has to be made. Who stays in the hospital and who can go home?
The rules are pretty stringent. If a woman just had spotting that has stopped, and you've excluded placenta previa and everything else is reassuring, she can likely be discharged home.
But the threshold for staying is very low.
Very low. All women with APH that's heavier than spotting or any woman with ongoing bleeding must stay in the hospital until the bleeding has completely stopped for a period of time. It allows for constant observation in case things escalate.
But this isn't just a checklist, right?
Yeah.
Clinical judgment has to play a part.
Oh, absolutely. Say a woman comes in with just a little spotting, but her history is that she had a previous stillbirth from a placental abruption.
You're not sending her home.
No way. The senior clinician is going to admit her for intense observation and surveillance because her personal risk is so incredibly high. You have to look at the whole picture.
Let's get into the specific medications, starting with the really critical role of antenatal corticosteroids.
Steroids are essential. They have to be offered to any woman between 24 and 34 plus 6 weeks of gestation if she's at risk of a preterm birth. And by definition, that includes women with bleeding or pain that suggests an abruption.
And their job is to.
Their job is to mature the baby's lungs incredibly quickly. They are proven to reduce the risk of neonatal death, respiratory distress syndrome, and brain bleeds if the baby is born early.
But what about dialysis? Drugs to stop contractions. In a bleeding situation, that sounds incredibly risky.
Your intuition is spot on. Dialysis is very restricted and often very dangerous when there's APH. It is absolutely contraindicated if it's a major bleed, if the mother is unstable, or if the baby is compromised.
Why is that?
Because if the uterus is bleeding, the contractions are actually the body's natural way of trying to clamp down on the blood vessels to stop the bleeding. If you stop the contractions, you might be stopping the body from saving itself.
So if it's ever used, it has to be a very specific scenario.
A very specific scenario decided on by a senior obstetrician. And the choice of drug matters. The guideline specifically warns against using nifedipine because it can cause maternal hypotension, which would be disastrous if she's already losing blood volume.
So the immediate crisis passes. The woman and baby are stable. Does that single episode of APH change how the rest of the pregnancy is managed?
Yes, significantly. If the APH was from an abruption or if it was unexplained, that pregnancy is now formally reclassified as high risk and her care must become consultant-led.
And what kind of extra surveillance does she need?
The main thing is serial ultrasound scans for fetal growth. APH is strongly linked with an increased risk of problems down the line, like the baby not growing well or low amniotic fluid. So you need regular scans to keep a close eye on the baby's well-being.
Okay, let's talk about the end game. Delivery. When do you deliver and how?
Well, if there is any maternal or fetal compromise, so instability or distress, the answer is immediate delivery, and that's usually by emergency C-section.
What about the tricky gray area the guideline highlights? The woman with unexplained bleeding that has now stopped and everyone is stable.
This is the major area of clinical uncertainty. The guideline is honest about it. The best time to deliver for these women is not established by high-quality evidence. It comes down to a senior obstetrician making a judgment call.
So if she's past 37 weeks, what's the general thinking?
If she's at term, say 37 weeks or more, and she's had a significant bleed that's settled, you should strongly consider inducing labor.
Why is that?
It's a risk mitigation strategy. The thinking is that you don't want to continue the pregnancy when there might be some hidden or occult placental problem that could suddenly get worse.
And what about monitoring during labor for any of these women?
It has to be continuous electronic fetal monitoring, or EFM. That's mandated for almost any situation involving APH-active bleeding, a history of a major bleed, suspected abruption. The threshold for continuous monitoring is deliberately very low because the risk of a sudden problem is always there.
The anesthetic team is so critical here. What's the preferred type of anesthesia for these high-risk deliveries?
Generally, a regional anesthetic, so a spinal or an epidural, is preferred for a C-section. It avoids the stresses of a general anesthetic, but it's strictly contraindicated if the woman is in shock or has a serious clotting problem.
And in a crash emergency?
In a crash emergency where you need to get the baby out in minutes, a general anesthetic may be the only option. And in any case, with major or massive bleeding, a consultant anesthetist must be involved. Their expertise in managing fluids and blood products is vital.
And finally, after the baby is out, you have to worry about postpartum hemorrhage.
You have to anticipate it. APH is a huge risk factor for PPH, so active management of the third stage of labor is strongly recommended. That means giving drugs to make the uterus contract down hard right after delivery to minimize blood loss.
Let's move to the highest level of emergency, massive APH. So that's over a liter of blood loss or signs of shock. This requires a whole systems approach.
It does. It requires a rehearsed protocol. The team has to be multi-consultant level, obstetrician, anesthetist, hematologist, all coordinated by a senior midwife. The blood bank has to be alerted immediately.
And the management is broken down into 4 pillars.
That's right. It's communication, resuscitation, monitoring, and the ultimate goal, to arrest the bleeding.
Let's focus on that last one, arresting the bleeding. In APH, why is delivering the baby and the placenta the key intervention?
Because delivery is what stops the bleeding. As soon as the placenta is out, the uterus can contract down like a massive natural tourniquet, clamping off all those open blood vessels. And just as importantly, you're removing the placenta itself, which is a source of factors that can trigger DIC, the clotting disorder.
In terms of resuscitation, what's the fluid strategy while you're waiting for blood?
2 big IV lines, 14 gauge if you can, and you rapidly infuse up to 3.5 liters of warmed crystalloid or colloid until the blood arrives. Warming the fluids is key because getting cold makes clotting problems much worse.
And if you need blood faster than the lab can work,
You can't wait. You give uncross-matched group-specific blood if you have it. If not, you give ORHD negative blood, the universal donor, immediately.
and how do you proactively manage the risk of DIC, that lethal clotting complication?
You have to treat it empirically if the bleeding is relentless. You don't wait for the lab results. The guideline says you should give up to 4 units of fresh frozen plasma and 10 units of cryoprecipitate. You're trying to replace the clotting factors she's using up as fast as possible.
What are the target numbers you're trying to hit with the transfusion?
You're aiming to keep her hemoglobin above 8, her platelet count above 75, and her fibrinogen level above 1.0. Hitting those targets gives her the best chance.
And what about women who are already on blood thinners?
That's a high-risk emergency. If a woman on something like LMWH or warfarin has any bleeding, she has to stop the medication immediately and get urgent assessment and expert advice from a hematologist. She may need immediate reversal of the anticoagulant.
Looking beyond the event itself, what does the guideline say about recovery, both psychologically and physically?
Psychologically, it mandates a comprehensive debriefing with an experienced obstetrician for the woman and her partner. This needs to happen early, with a follow-up appointment arranged and the offer of psychological support.
And physically, there's that counterintuitive risk of clotting, isn't there?
There is. A major hemorrhage and blood transfusion are both risk factors for VTE or dangerous blood clots. So thromboprophylaxis clot prevention has to be started as soon as the immediate bleeding risk is over.
The guideline also pushes for system-wide improvements through auditing and training.
Yes. Major hemorrhages must be reported as clinical incidents for learning, and it stresses the critical importance of incorporating APH management into regular obstetric skill drills. These drills have to be multi-professional, including anesthetists and blood bank staff, to really improve teamwork and response times.
Finally, even with all these detailed protocols, the 2011 guideline was honest about its own limitations. It identified key areas where more research was desperately needed.
It did. The first gap was about preventing abruption. We need large-scale trials to really figure out if things like diet, specific supplements, or antithrombotic therapies can actually make a difference. We need more than just observational data.
And the second gap was about that clinical tightrope walk we discussed earlier.
Exactly. We still lack the data to determine the optimum timing of delivery for women with that settled, unexplained APH when everyone is stable. Right now, it's all down to senior clinical judgment, which can lead to variation in care.
And the third gap was about managing the most critical phase, the massive transfusion.
Right. We need more data on the best transfusion ratios in obstetrics. What's the optimal mix of packed red cells, fresh frozen plasma, and cryoprecipitate to get the best outcomes? We've borrowed a lot from trauma medicine, but we need specific obstetric data.
So today, we took a deep dive into the RCOG guideline on antepartum hemorrhage. We learned that management really hinges on these strict definitions: spotting, minor, major, massive, and an immediate discipline triage that always puts the mother first.
We established that abruption is largely unpredictable, which means clinicians have to maintain this high index of suspicion. And we detailed that critical mobilization of the whole team, the multi-consultant response, and the blood pipeline needed to control the bleeding, with the ultimate goal being delivery.
But our journey through this guideline really did reveal a core ambiguity, something that's still at the heart of daily obstetric practice.
And that's really our final thought for you to consider. Despite APH being a leading global cause of maternal death, and despite all the clarity we have in managing the acute crisis, why do these crucial decisions, like the exact timing of delivery for a stable woman with unexplained bleeding, still have to rely entirely on senior clinical judgment instead of definitive evidence?
What further large-scale trials are needed to close those critical knowledge gaps, to remove that ambiguity and ensure that every single patient gets the exact same evidence-based standard of care? A profound question that really underscores how medicine is always evolving. Thank you for joining us for the deep dive.